All right, welcome everybody. It is July 5th. Hopefully you had a great July 4th holiday. This is Peter M. Pevy along with Ken Smita. We are hosting the Florida EMS webinar, and today we have an amazing guest. Many of you probably know Mike Lauria. He's a renowned speaker. He goes across the country. We see him at many of the meetings. He's a great, great speaker. And what caught my attention was a paper that he recently wrote on tourniquet conversion in civilian EMS. Something that many of us should know about. So he wrote a paper on a case report, plus just some of the guidelines that we all need to be aware of. So without any further ado, Mike, thank you for joining us and welcome to the show. Take it away, my friend.
Hey, no problem. Peter, Tanner, thank you guys so much for having me. Stoked to be here and talk about a topic that is near and dear to my heart, which is trauma management in the field. And specifically, we say it's a newer concept, but really, if you look back, we've been talking about it since like 2008. I think it's really just kind of coming to the forefront at this point. But without further ado, so, by way of background, I actually started out in the fire service myself, and then actually, because I had some baseline chemical imbalance, like most of us, I actually finished my undergrad and then enlisted in the military. So I was a PJ in the Air Force. I did combat search and rescue and direct action support for various special operations teams around the world, which was pretty cool and fun. And then got out and started working as a flight paramedic. And like many of you, like flight paramedic, ground paramedic, teacher, trainer, like five jobs to make ends meet in the EMS world. And then, as evidence that I had really hit my head way too hard on a number of occasions, I decided to go back to medical school, did residency here at UNM, and then fellowships in EMS and critical care, which has been a blast. But what I wanted to talk to you guys about today was really the tourniquet stuff. And specifically, I'm sure anybody who's working in the field at this point understands the most of the benefits of tourniquets and how they work. But what I really want to do is go over a couple highlights, and then number two, touch on some of the complications that we don't talk about too often, but I think are actually really, really important to recognize, and then the whole tourniquet conversion protocol. And that should bring us to about 20 minutes or so. And then we can have some really fun discussion on stuff. So let's start out with number one, the benefits of tourniquets, some other data on tourniquets. So before we get into tourniquet conversion, I think it's actually really important to talk about some of the pitfalls that we've identified with tourniquets, and some of the really important highlights that I continually see in a lot of Q&A stuff and questions I get asked at conferences and whatnot. So as you guys are well aware, probably one of the most important things to trauma is early intervention. And it was Nicholas Sen, who was actually an American surgeon, who essentially had said the fate of the wounded lies in the hand of the one who applies the first dressing. In this case, the first tourniquet, or in this case, who gets hemostasis, I think is really like the important take home there. And tourniquets have been an important part of those. I mean, unless you've been asleep or anesthetized for the past like decade in EMS, it is definitely something that has come to the forefront, mainly as a result of some unfortunate situations around the world. But as it's sort of come over into the civilian world, I think we're noticing some significant benefit. Now, the tourniquet data from the military, we could spend like an hour reviewing the various meta-analyses and all the data that's come from the Joint Trauma System. However, in summary, I think it's fair to say that consistently and overwhelmingly, tourniquets have demonstrated significant benefit as it relates to mortality and morbidity when it comes to exsanguination from extremity injuries. Some of the highlights, I think, if you read, there's a great meta-analysis by Dunn and his colleagues that looked at all the data from 2003 to 2011, which showed if the tourniquet was applied early, that people had like a 96 to 97% survival. Whereas before, early on in the conflict, like pre-2003, it was a very different story. There was another very good systematic review by it was Mawini and his colleagues that looked at it, showing the very clear mortality benefit. And it just goes on and on and on as we compile the data throughout the conflicts. Now, interestingly, but I guess not super surprisingly, it took a little while for the civilian world to catch on, right? So there was a sharp rise in use starting in about 2008 to 2010. And that was thanks to a lot of the work that was done through NREMT and PHTLS that actually recognized this as like legitimate. Before then, there were some very avant-garde, very progressive medical directors that I think were incorporating this stuff. But if you look at the numbers pre 2008, I think there and like large registry data, there was very few tourniquet use, very little tourniquet use. But if you look at like from 2008 to 2016, you're looking at more than 3,900, almost 4,000 documented uses in some of these larger databases. And when they're retrospectively reviewed, it seems to demonstrate similar benefit if you match the patients by injury severity and location of injury and all that other stuff. So I think overall, what we've seen is yes, it definitely helps in the military and the injury patterns that we see in the military. And it seems to be doing the same if there are similar injuries in the civilian world, which I think is really interesting. And that's not super surprising. The extension of that, of course, is the Stop the Bleed campaign. We've actually pushed this from just like EMS medical providers in general to civilians, which I think is fantastic because they will be there they will see the hyperacute trauma, the people next to them, the people around them, and be able to apply this first. And one thing I do tell people, it is very easy to look at the military data and to say, well, the SEALs use this and PJs use this and, Army infantry uses this. We should be using this too. Just be very careful about how we interpret and read the data in terms of the injury patterns and how this stuff is applied, how the training is done. It is very different in some cases. And there's actually been a couple of papers looking at mass shootings and whatnot, and the injury patterns. We often talk about these cases are great for tourniquets, and they are if people are shot in extremity. However, what we're seeing in some of these larger incidents is that unarmored civilians getting shot in the torso and head and neck much more frequently in some of these cases than in some of the military setting where we had a lot of. You look at these big databases, there are a lot of IEDs, so blast injuries, shearing off and just mangling extremities, and then gunshot wounds to the extremities, sparing the torso time because of body armor and whatnot. So just be careful. I'm not saying I'm against it in any way, shape, or form, but just be really careful when we read the military data and then try and apply it to the civilian world. Now, before I get into some of the specifics about complications from prolonged tourniquets being applied correctly and being in the right place, I just wanted to go over some pitfalls and challenges that I still see with tourniquets in various medical systems and patients coming into the emergency department. First of all, there are still fakes out there. Please, if you are running an EMS system, if you are in charge of purchasing, make sure that you're getting a tourniquet that is A, approved, and B, is legitimate. There's all these knockoffs that are coming from around the world that have entered the supply chain, and that is really bad. They break really easily. They don't do their job nearly as well, and we've noticed a number of problems with them. So just make sure you're using an approved one, preferably one of the that's on. I think they updated recently the list of approved, which has not changed significantly, but just make sure they're on there. Time. This is always a question, and there's two pieces to this. One, the biggest pitfall is waiting too long, trying to hold pressure or put pressure on a wound that is actively bleeding and hemorrhaging under your hands, and you just wait too long to put the tourniquet on. And the other piece of time is how long to leave it on. And that is actually one thing we're going to talk about in a little more detail. But safe to say that essentially less than 2 hours is very reasonable. 2 to 4 hours, we're not exactly sure, but that's where we start to see the first signal of some of these prolonged injuries. And above 6 hours is where we've really seen some bad stuff. That's, of course, a little less likely in the civilian environment, but it's still in cases like search and rescue or prolonged care in the field, does pop up from time to time. I'll talk a little bit more about that here shortly. How tight? The other mistake we see is not tightening it down completely before twisting the windlass. We've seen this a number of times where it's still not that tight after the windlass has basically been twisted off of the tourniquet. And it's because they forgot to really cinch it down before they started tightening the tourniquet. We used to teach people high and tight. So that was like the classic mantra in the military and how we started teaching people in the civilian world. We used to say things like, well, if it's, like around the distal arm, the radius and ulna prevent it from compressing the arteries, or the fibula and tibia prevent it from compressing the arteries. As it turns out, that's not the case. We should be basically just applying it a couple of inches above the wound. The caveat to that is if you can't see where the wound is. So, for example, if it's in the middle of the night, you're trying to extricate someone from a car and you can just see them or feel them like actively hemorrhaging from somewhere. They're sitting in the car and it's like somewhere on their thigh, and you don't really know exactly where it is, but you're pretty sure it's on the thigh somewhere. High and tight is certainly reasonable until you can get them extricated and actually examine it. We still teach it in tactical medicine. So if you're working with a TEMS unit or a paramedic for a TEMS unit, I think it is very reasonable, especially in care under fire or field care, tactical field care, to actually apply it very, very quickly, high and tight. And then as soon as you get a chance, reassess things, just because taking the time to cut someone's clothes off and find exactly where they're bleeding is operationally problematic, let's just say, under those circumstances. Another thing that we still see sometimes is intermittent loosening. People not necessarily doing a tourniquet conversion, but just like burping the tourniquet from time to time. As it turns out, it's not really reperfusing anything. It's just causing like a bloodletting, essentially, and a regular interval of hemorrhage. So not exactly what we would recommend at this point. And we still see, and this is understandable, and I've done this too. Many tourniquets placed that may not necessarily need to be placed on like venous bleeding and stuff. We've done a great job of training people, but now the pendulum has swung, I think, a little bit too far. And that is understandable in our environment because if you can't exactly see what's going on, you can't exactly identify how bad it's bleeding, but you're concerned, sure, throw it on. I would rather that than let someone like exsanguinate as they're being carried out of their house or extricated from a car or something like that. But point being that they may not need it. You may not always be able to recognize it in the moment. And this, I think, is yet another argument for why reevaluation and possible tourniquet conversion are very, very important. So, complications of tourniquet application. Nothing we do in medicine is like completely benign, whether it's like giving fluid or putting on a tourniquet. Nothing is without cost or completely benign. And this is absolutely the case with tourniquets as well. So the complication rates that are reported with a lot of tourniquets, and this is retrospectively looking at mainly military data, is at face value, like not super concerning. Most of the rates of major complications, when I say major complication, I mean something that is altering the functionality of that limb or causing serious systemic problems. And we'll go over some of those examples here. So some of those things, like let's say, for example, the rates reported are like between 1.7 and 3-ish% of tourniquet applications. And it varies based upon the time interval. The higher, the longer the tourniquet is on, the higher the risk, especially once you get beyond 2 hours. But what's interesting is that some of the things you look at, like, deep vein thrombosis. So like you apply the tourniquet correctly. It's on for like an hour and a half or 2 hours, and someone gets a DVT, which doesn't sound that bad. You're like, oh, well, we can treat a DVT. Not necessarily completely benign, right? Because if someone has a legitimate DVT, they have to be therapeutically anticoagulated for up to about 3 months. That is based that as an extrapolation from other forms of DVT, why other people get other DVTs, but that's what they would do. That's how they would be treated. So imagine being completely therapeutically anticoagulated for 3 months, being a firefighter or a cop, or like if you were in the military, we wouldn't allow you to go back to active duty. Like we're not going to put you into combat on a DOAC, right? Or like being, like on warfarin or something. That'd be insane. Like just run out there and try to get that blown up with, completely therapeutically anticoagulated. So there are consequences to even some of these small, non-life threatening and treatable things. And we should be aware of those. And we should work really hard to minimize those. So venous and arterial thromboembolism is absolutely one. Venous more so than arterial, but you can imagine if you actually tighten that sucker down correctly and cut off arterial flow, having arterial occlusions is absolutely a complication. The other thing is tissue ischemia, which in general, and I think this is very interesting because a lot of the data, like when we originally taught in like 2005, like when I started the PJ pipeline, people were like, oh, you can have a tourniquet on for more than 4 to 6 hours with no damage to the tissue and reperfusion's fine and there's no issues. Well, that was largely an extrapolation from the orthopedic surgery data. I think we can agree that a 28-year-old who's been, blown up and has multiple shrapnel injuries and is essentially exsanguinated and is getting resuscitated with blood products and has a tourniquet on their thigh is very different from the active 28-year-old skier who comes in and is going to have surgery to their knee and they get a tourniquet placed on their thigh. Those are very, very different physiological milieus. And so it's not probably the most accurate to extrapolate that timeline from healthy people who have a tourniquet put on a healthy extremity to people who are in profound, profound shock and now also have a tourniquet on. So just again, this is carefully interpreting the data and being careful about how we extrapolate some of those numbers. Severe pain and discomfort is one. I have literally had a dude punch me before because I put on the tourniquet appropriately and it was cutting off blood to their like blood flow to their extremity. It's extremely painful. Like if you ever had it done to you and like in training to cut off arterial blood flow, it is really tight and it is really uncomfortable, especially if there are injuries in proximity to where you're putting the tourniquet. I don't think we should necessarily, it is treatable, right? But again, especially looking at the data for people that are super jacked up and have these tremendous, tremendous traumatic events, near death events, additional pain and suffering is not completely inconsequential, especially when the rates of PTSD and psychological issues from these really bad incidents are high. The last thing is, and this is where I really get concerned. This is where I see patients in the ICU and the ED in the ICU for major, potentially life-threatening complications. So if a tourniquet's been on for more than 6 hours, this is where we start to see an inflection point in the data that shows not just things like local tissue damage or nerve injury or thromboemboli, but we see really significant issues with reperfusion injury. So you wash out all the junk that's in that leg after 6 hours in someone who's already very pro-inflammatory from their shock state. And we see things like rhabdo and oliguric acute kidney injury. So all that stuff getting washed out really quickly and they're already in shock and their kidneys have already taken a hit. And now you wash all this junk into their kidneys. That is a big problem. Going on dialysis temporarily is a big problem. Acute hyperkalemia from all that stuff washing in your system. That is a big problem. We also see things like, believe it or not, acute lung injury and ARDS from some of these, from some occasionally, but definitely in the setting of significant compartment syndrome. So you reperfuse all that tissue, all of that, those pro-inflammatory cytokines get washed out. Your entire blood volume goes to the lungs. So that can actually cause pretty significant lung damage. And in terms of acutely in that compartment, when it gets reperfused, swells up, and now you once again cut off circulation because the compartment swells. That is a problem that requires surgical intervention, fasciotomy, and then they get to come hang out with me in the trauma surgical ICU. So, all of these things are very real complications. And again, when you look at you like think like 1%, 2%, 3%. But if we're applying 4,000 tourniquets, that's what, like 120, 130, 150 people somewhere in that realm. And I wouldn't want to be one of those 150 people. So we should acknowledge those complications and we should be wary and we should be able to treat them. So how are we going to do that? Well, we're going to do it with tourniquet conversion. The precise timing, again, it remains unclear. We really have to study this prospectively in order to kind of figure that out exactly where those inflection points are. But we have a general idea from retrospectively looking at things, and that gives us some general guidance. Okay. So when? I would convert a tourniquet ASAP as long as you have the time and availability of resources. And we'll talk about that a little bit more in a second. If it's essentially less than 2 hours, I would say go for it. Get the equipment together. If you have the time and you have the you have the cognitive headspace to deal with this, i.e., it's not in the middle of a mass casualty. You're not trying to concurrently manage several other patients. You don't have other more pressing issues in terms of interventions to do. Go for it. 2 hours to 6 hours, we'll say use caution, but generally okay. And if it's been more than 6 hours, so this would be in the setting of like wilderness search and rescue, austere search and rescue, someone who, if you're an air medical team, you're flying out to a critical access hospital and find a patient there who's actually like had the tourniquet on since their initial trauma more than 6 hours ago, use extreme caution. This is where we really start to see some of those reperfusion injuries, and you can see the acute hyperkalemia, kidney injury stuff where we really need to monitor these patients. It is possible to do it if you have advanced monitoring. So if you're at like an austere clinic and you can get like iStats, point of care labs, you have the ability to give fluid, monitor their heart rhythm, get a 12 lead, administer all the hyperkalemia drug, like all of that stuff. You can manage those complications. Probably reasonable to do it carefully. But as far as doing it in the pre-hospital environment without some of that stuff, we can't necessarily recommend it yet. So
Mind
when
if
you should
I
not.
have a quick question for you?
Yeah, yeah, absolutely. Absolutely. Go for
Can
it.
you just, if you can just expand on tourniquet conversion, it's essentially it's hemostasis using pressure and gauze at the wound site and removing the tourniquet. Is that what you're
Yes. Yeah. So I
doing?
was going to go through the procedure in a second, but Peter brings up a really good point. To better define exactly what I'm talking about when I talk about these numbers, it is essentially converting, not just letting up on the tourniquet, but cautiously and effectively converting the tourniquet by placing a pressure dressing, packing the wound, placing a pressure dressing, and then slowly and carefully relieving the pressure or letting the windlass go and restoring blood flow to that extremity. So that's what I'm talking about. A careful procedure that is transitioning a tourniquet to a pressure dressing. Sorry, I probably should have like better defined exactly what I was
It's all
talking about
good.
right up front.
It's all good.
Okay, so when not to attempt this. Um, Most of the civilian and military guidelines basically say there's three no-goes. They're still in shock. They have a complete distal amputation. At that point, you're really not reperfusing anything, so I wouldn't worry about it. And or the wound can't be monitored, so you don't have the personnel or availability to actually monitor the wounds. This would be like again a mass casualty situation. You're in an aircraft where you can't access their extremity or monitor their extremity closely if they start to hemorrhage again. Anything where you couldn't address sudden bleeding just because you recently took the tourniquet down. I really do want to make one point that I try and get across to both providers and medical directors. When we say persistent shock, I don't just mean a systolic blood pressure less than 90. I would actually include in there, I don't have data to support this, but I do have some relatively strong feelings about this, is if they're in a compensated state. In other words, if their shock index is high. So if their shock index, and we define that as their heart rate over their systolic blood pressure, is associated with poor outcomes in the setting of trauma, specifically in other instances as well. But if you think about it, it does make sense. We know that shock index greater than 0.9 is associated with increased mortality, increased transfusions, and a bunch of other stuff. But to highlight what's going on, just bear with me one second. I'll give you an example, right? So let's say you're chilling out and you're just listening to me blab on about tourniquets, and your heart rate's in the 60s and your blood pressure is like 124 over 82. Your shock index is going to be 0.5, right? Your systolic blood pressure is your heart rate is 68, your blood pressures or systolic blood pressure is 124. Great, right? Now imagine you have a healthy 34-year-old who's in the field, has been shot multiple times in the abdomen or the extremity and has been hemorrhaging, and his heart rate's 144 and his systolic blood pressure is 104. His shock index is 1.4. High risk for death, definitely going to need a transfusion, et cetera, et cetera. Do not think that that person is not in shock or at risk of dying from shock just because his systolic blood pressure is over 90. Please, please, please. I see this on a regular basis in the trauma bay. I've seen it absolutely 1,000% in the field. Like a healthy Marine will look at you with a heart rate of 152 and a systolic blood pressure of 98 and say thank you and talking to you, and then Brady down to a heart rate of 0 and die within like minutes. They will maintain and they will continue to maintain a reasonable blood pressure and then just die. So, not just shock, but I would say elevated shock index or at risk of dying from hemorrhagic shock. The one additional caveat that I will give you before I actually go over the procedure is, and this is an operational consideration in the EMS world, I would throw underneath category 3 that inability to essentially monitor it. If you don't have the brain space to do it because you're also trying to talk on the radio, trying to coordinate, trying to give a report at the hospital. Oh my gosh, this person has a pneumothorax too. I think if there are other evidence-based interventions that need to be done that can save a life, then do those first, and this would get deprioritized, I would say, especially if you're anticipating on and being in the hospital in less than an hour. Okay, so the procedure. It is relatively simple. And again, like why I think we should be doing this more often. Number one, we do recommend, or at least most of the recommendations have been saying, look, put a second tourniquet above it. God forbid you undo the first tourniquet and it break, it busts, part of the windlass comes off, or something happens. Having a backup in place, not tightened, but just loose above the first tourniquet in case something goes wrong, is, I think, reasonable. Expose and take a look at the wound and make sure it's not actively bleeding. If it's still actively bleeding, you should probably tighten down the tourniquet, or make other interventions, as in tighten down the tourniquet and then still putting a dressing on would be reasonable. But I would not completely convert the tourniquet at that point. So expose and take a look at it. Simple step 4, go ahead and pack the wound and put on a pressure dressing like you guys have been trained a million times to do. And then very slowly, and these are random numbers. I don't know where I keep on getting questions like, well, how do you know? Like, is it a quarter twist every 10 seconds or a quarter twist every 20 seconds? I don't know. We just like basically made the number up. And no one has good data on this. The point is go slowly. Undo it, quarter turn, half a turn, every 30 seconds or so. Keep an eye on it and make sure it doesn't actively start to bleed. If you've packed it well, keep an eye on the dressing itself and make sure there's not blood leaking out from under the pressure dressing or the pressure dressing is just soaking through. If that was the case, I would take that as a sign that there's active hemorrhage and I would reapply the tourniquet. I would tighten it down again. And then just continue to monitor them. So after the windlass is completely loose, just continuing to monitor them is absolutely reasonable, and keeping an eye on it every couple minutes, I would say. But you really got to watch it pretty closely because we've definitely had anecdotal evidence that everything looks fine, but everything looks fine because it's soaking through the combat gauze and soaking into the dressing. And 4 or 5 minutes later, you see like blood dripping around the dressing and it's actively hemorrhaging. So just keep that in mind. Where do I think this comes in particularly handy? Well, in prolonged field care. So definitely, if you are a search and rescue provider doing stuff in the wilderness, long carryouts, the medical director for one of these programs, or a tactical medicine team. I think this is probably number one on my hit list of people who I would encourage to do this. Um, the There is, I think, absolutely a place for it in conventional EMS because we don't really know how many of these complications are occurring before 2 hours. If you have a half-hour ride to the hospital and the call was for exsanguination from an extremity, and otherwise that person is fine, isolated and traumatic injury to that leg, totally reasonable in the back of an ambulance on the ride to the hospital to do this. Absolutely. If you are in the process of, if you're in a rural community and you're now interfacing with air medical transport or some other EMS agency that will be transporting that person, and you're sitting there waiting, and you have the opportunity, and there's no other critical interventions that need to be done, it might be beneficial, if for no other, a bunch of reasons, but you're going to save giving that person pain medication. You might actually prevent the tissue injury and whatnot. So even in a conventional setting, if you have the time and that tourniquet is on, I would reassess it. I would absolutely reassess it. I like to tell people, because of what I hear over and over again, is they can do that at the hospital. They can absolutely do that at the hospital. Wait till the hospital. We have other things to do. Let me put it this way. If you have time during the transport to sit down and chart, what they had for breakfast, then you have time to probably, your time is probably better spent at that point making sure this tourniquet isn't doing any significant damage and actually taking it down or converting it if it is safe and practical. So it's about that. And I think of these interventions, not just like they give them blood and decompress their chest interventions, but interventions that actually help on the deresuscitative side or prevent injuries from some of the things we've done, including things like tourniquet conversion. So where's the data? Show me the data, right? Like, how is this helpful? How is it beneficial? Well, I'll be honest with you, there's not much at this point. We kind of think it is safe and it is reasonable, and there's equipoise to do it, to trial it, to study it, but we don't really know. The best we have is like anecdotal data that's coming out of the Ukraine that hopefully will be published sometime soon, but we don't have really, um, really good numbers. We don't have good numbers on timing, whether it's better in half an hour or an hour, or it makes no difference in less than an hour. We don't know about like which injuries occur at which time frames. So I think we do need to kind of roll this out, studying it and monitoring it carefully in a prospective manner to see if it's feasible, if it's safe. Are we actually going to hurt people more by trying to take down these tourniquets? And if the answer is no, we're not hurting people, and yes, we may be helping people, and there's equipoise to actually study it in a randomized fashion, then I think we should. But right now, we really need to study it a little bit better. So we talked about some of the benefits. We talked about some of the complications and problems, and then went over when we should do it, how we should do it, and specifically, probably most importantly, when not to do it. So at this point, I would be happy to open it up to questions and discussion.
Mike, that was incredible. I learned a lot of small items in there that I did not know before, and um, I know we have a few people here that are on, but I have my question for you is, you know, we do have a lot of police officers who place tourniquets, and I wonder if they place a tourniquet and we see that it's inappropriate. I have a feeling that our folks would not remove tourniquets once they're already on the scene. Would you advise an urban, suburban, like most of us on this call are, to just say screw it, leave it on, or are you of the notion of it's worth evaluating every single wound, even if a tourniquet's been placed on prior to your arrival? You see where I'm going with that? What are your thoughts on that?
Yeah, so my personal belief, and again, not super data supported at this point, but having managed some of these complications in the ED and the ICU that are not insignificant, I would say that it should be essentially every wound, again, with those caveats that they're not in shock, that you can monitor and control the hemorrhage, and that operationally you have the brain space to actually think about it. I think that the bigger issue for us is that we should be reassessing it. But again, a lot of these scenes are like so chaotic that I kind of recommend, unless you're sitting there for a long period of time with no transport available, it would kind of be for me diverted to like in the if you'd like give it the tactical equivalent like CASEVAC care or tactical evacuation care, whatever you want to call it, and then the transport phase. So like when you have a like at least 1-to-1 provider ratio, 2-to-1 provider ratio would be nice for transporting someone like this. And everything else is taken care of. It should be, I absolutely think they should all be reassessed. Does that answer your question, Peter?
Yeah, it does. It does. Let me bring in Tanner, and then we have a few other people coming in. Tanner, you have a comment or question?
Yeah, a couple comments. So as an update from the West Virginia chapter of NEMSP, our state is releasing a new suite of protocols mid-July, and tourniquet conversion is one of the new protocols. So statewide in West Virginia, BLS providers, ALS providers, they'll be able to convert tourniquets in the pre-hospital setting. Ahead of this webinar, knowing that you were coming on to talk about this, I spoke to our state EMS medical director about kind of the rationale behind the decision to implement this protocol and some of the reasons behind it. And he kind of echoed many of the sentiments that you echoed. So some of the things he specifically mentioned is that as tourniquet usage is kind of permeating out, civilians are now kind of carrying these in first aid kits. Police officers are carrying them. we're seeing a lot of people coming in with inappropriately placed tourniquets that weren't even necessarily placed by EMS providers.
Yeah.
In addition to that, one thing that he said was a specific problem is basically EMS providers will take patients to critical access hospitals, and the personnel at the critical access hospitals will not be taking down inappropriately placed tourniquets and waiting until these patients are transferred to, the level 1 trauma centers in the state for assessment by vascular surgeons. And that's really where we see huge delays and a lot of morbidity. And he mentioned including some lost limbs. And so I think that underscores your point that, it's not just about time to transport to the nearest hospital, but it's time to definitive intervention. And so, delays that happen after hospital arrival should also be considered. But yeah, thank you very much for this presentation. Really, really excellent.
Yeah, no problem, man. And I think you brought up a really, really good point, which is the presumption that it's going to happen at the hospital, which is not always the case. And I'm sure you guys see that in Florida and West Virginia. It's absolutely a thing out here in New Mexico where they will get to a small critical access hospital. They'll be auto accepted by like the trauma service at UNM or another regional level 1 trauma center as soon as someone can come to get them, or as soon as the weather clears and we can fly an aircraft out to them, which is not uncommonly more than 6 hours from the time of injury to the time that they're actually arrive at the trauma center. And then, by the time they get to the trauma center, most of the trauma surgeons are very good at it, but they'll call vascular. They'll do like studies with like runoff, and they'll be like, oh, there's a vascular injury. Like it's because of the tourniquet. Well, yes, but it was probably because the tourniquet was on for like 12 hours, not necessarily the initial placement itself. So that's a fantastic point, that the presumption sometimes is that when they get to the hospital, they will have it off. And it's actually interesting because I think a lot of the time what we are seeing with a lot of these interventions, and you guys tell me if your experience is different, we have a very progressive EMS systems and very progressive medical directors and people that are coming into the community who go to a lot of these conferences, and information is actually getting permeated out about trauma management through the EMS system faster than it's hitting our rural providers, our colleagues in emergency medicine, NPs, PAs, and other APPs that are working in some of these very critical access hospitals. If we're even lucky to have some with emergency training. So I would say it's even more paramount because I think EMS is going to lead the way in this particular area.
Perfect. Great comment. I want to bring in Dr. Matt Levy from Hopkins. Matt, you're in this space. You made a good comment earlier. If you want to unmute and provide your commentary, we'd love to hear it.
Great job. Fantastic talk. You really, really contextualized and presented a lot of information very concisely. I couldn't agree more with everything he said. We saw this kind of freight train coming, exactly what he had mentioned, what Tanner had mentioned about issues with that clinical inertia, which is very real in resuscitative medicine, which is things start happening and then they keep happening because they've happened. And so being able to train and equip our responders and our clinicians to course correct is really important, be that for an airway, be it for a tourniquet, be it for anything. We put together what was really the first attempt at a civilianized version of the Tourniquet Conversion Guidelines, which Michael did a wonderful job speaking to today. Peter, thank you for sharing it in the link. If it's of help to anyone, if full disclosure, it was really meant for the scenario that Tanner really talked about, which is these critical access hospitals or these community EDs where someone walks in with a tourniquet on, well-intended, maybe not necessary, maybe necessary and well-intended, and to provide guidance for that. But the next iterative step here is empowering our pre-hospital clinicians when it's safe and appropriate. And I think it's all about when it's safe and appropriate. So that's all. Great job, Mike. Seriously, home run. Nice done. Nicely done.
Oh, thanks, Mike. Appreciate it, man.
All right. Well, both papers are now in there. So the paper that Dr. Lauria wrote with his team and the one that Dr. Levy wrote with his team are now in the chat. I think both of those are important. And it's clearly a progression here. It's almost like stroke care, where for many years, EMS was just taking stroke patients to hospitals. Now they know so much about what should happen that they're literally in the ED looking at the nurses and doctors saying, like, why are you guys doing this? Because they understand it. The same thing should happen perhaps with tourniquets, where if a tourniquet was placed, and Dr. Lee from Brevard is making good commentary that if there is an inappropriate tourniquet, or if you go to an outlying access hospital and you recognize these people aren't going to do anything with that tourniquet, perhaps it's time to step in, say something in order to prevent some of these complications that Mike was talking about here, because you don't want to be one of those 150 people. I think that's stated very well. And hey, I mean, 4,000 tourniquets a year with all the stuff happening in this world, I'm surprised it's not gonna, if that number doesn't go higher. And perhaps that's another good large database study, whether it be from NEMSIS or another ESO study, what have you. I would love to see that information. So with
Yeah,
that,
absolutely.
Mike, I'm going to give you the last word. Take us away. You have a lot of people here who have protocols that just say, place a tourniquet high and tight. You give us a lot of context and perspective. Give us your last words and take us away.
Yeah, first, before I give my last word, I did want to thank Matt and his colleagues, because it's interesting. I didn't know Matt was going to be here, and a lot of the stuff that they put out was some of the stuff that I was looking at on the civilian side. So I'm glad, I'm glad Matt is here and gives me the ominous dominus that I actually interpreted what they did or what they recommended correctly. So thanks to Matt and his colleagues. I just wanted to say that, kind of tying in that last thing I said, that this is an area that I think is not just an important part of the clinical practice of trauma medicine, but this, because we are so focused on it, and because we are very focused on trauma care, and we are very focused and dialed in on the evidence and the data behind how some of these things work, as well as operationalizing that in the field sooner before they get to the hospital. This is another one of those ways, like I said, that I think EMS is going to lead the way in terms of changing the tide of things, because I really think that, especially in areas outside of level 1 academic trauma centers where we're already discussing this is not being discussed. And it will, as really squared in crews, where just squared away, dialed in crews are coming in and explain their justification for how they did the tourniquet conversion and why. And I think that will actually really get a lot of people on board, especially in smaller emergency departments and critical access hospitals. Like, oh my gosh, wow! Like the EMS team was able to do this. The paramedic team that brought this guy in or did it with tourniquet conversion. That really a thing? I'm sure we'll hear. All of us who are medical directors will get more phone calls. But I think it's another way that I think we're going to lead the way in changing how we provide trauma care.
Awesome. That was a great takeaways. I'm going to be adding this to my list of my quarterly medical director meetings. So thank you guys, both Mike and Matt, for that. So, all right, everyone. Thank you so much. This will be on YouTube a little later on. You can join the link. I put it in the chat for Dr. Pepe's webinar, which is ongoing right now. I'll put it in again. I'll be on here for another 30 seconds or so before we shut it down. Mike, thank you so much. Tanner, Matt, everybody, happy Friday.